Hello, good afternoon. Welcome once again to my YouTube channel, and today I'm going to talk about how you can manage malaria when you're pregnant, and even after you get malaria, how do you treat it? So the World Health Organization recommends a three-pronged approach to malaria in pregnancy, which includes number one, intermittent preventive treatment, number two, insecticide treated nets, and number three, prompt and effective case management. World Health guidance for each prong is as summarized below. Intermittent preventive treatment in pregnancy. Above this, in areas of moderate to high malaria transmission, intermittent preventive treatment in pregnancy with sulfadoxy-pyrimethamine (SP) is recommended for all pregnant women at each scheduled antenatal care visit. World Health Organization recommends a schedule of 4 antenatal care visits. The first IPTP-SP dose should be administered as early as possible during the second trimester of gestation. Each SP dose should be given at least 1 month apart. The last dose of IPTP with SP can be administered up to the time of delivery. At that time, after 3 months, there is no risk, so it is just okay. There is no worries that is going to hurt the mother or the pregnancy, so you can just give. IPTP should ideally be administered as directly observed therapy or DOT. SP can be given either on an empty stomach or with food. Folic acid at a daily dose equal or above 5 mg should not be given together with SP, as this counteracts its efficacy as an antimalarial. World Health Organization recommends daily iron and folic acid supplementation in pregnant women at the dose of 30 to 60 mg of elemental iron and 0.4 mg of folic acid to reduce the risk of low birth weight infants, maternal anemia, and iron deficiency at term. SP should not be administered to women receiving cotrimoxazole or ceftriaxone prophylaxis. Number two is insecticide-treated nets or ITNs. ITNs should be provided to women as early in the pregnancy as possible at the ANC clinic or through other sources in the public or private sectors. The World Health Organization Global Malaria Program recommends distribution of ITNs, more specifically LLINs, to achieve full coverage of populations at risk of malaria. The best opportunity for rapidly scaling up malaria prevention is free or highly subsidized distribution of LLINs through existing public health services, both routine and campaigns. Diagnosis. Prompt parasitological confirmation by microscopy or alternatively by ARC-DTs is recommended in all patients suspected of malaria before treatment is started. Treatment solely on the basis of clinical suspicion should only be considered when a parasitological diagnosis is not accessible. Treatment. Effective case management of malaria. Effective case management of malaria illness for all pregnant women in malarious areas must be assured. Uncomplicated malaria. Pregnant women in the first trimester with uncomplicated falciparum malaria should be treated with quinine plus clindamycin for 7 days and quinine monotherapy if clindamycin is not available. Artesunate plus clindamycin for 7 days is indicated if this treatment fails. Specifically, first trimester, quinine plus clindamycin to be given for 7 days, into brackets, artesunate plus clindamycin for 7 days is indicated if this treatment fails. If clindamycin is unavailable or unaffordable, then quinine immunotherapy should be given. And ACT is indicated only if this is the only treatment immediately available, or if treatment with 7-day quinine plus clindamycin fails, or if there is uncertainty about patient compliance with the 7-day treatment. Second and third trimester. ACT known to be effective in the country, region or artesunate plus clindamycin to be given for 7 days, or quinine plus clindamycin to be given for 7 days, with the exception of DHA plus PPQ, for which there is insufficient information in second and third trimesters of pregnancy, to use as first-line therapy. Note: if clindamycin is unavailable or unaffordable, then the monotherapy should be given. Patients with HIV infection who develop malaria should receive prompt, effective anti-malarial treatment regimens as recommended in the relevant sections of these guidelines. Treatment or intermittent preventive treatment with sulfadoxine pyrimethamine should not be given to HIV-infected patients receiving cotrimoxazole, trimethoprim plus sulfamethoxazole prophylaxis. Complicated malaria. Parenteral antimalarial should be given to pregnant women with severe malaria in full doses without delay. Parenteral artesunate is preferred over quinine in the second and third trimesters because quinine is associated with recurrent hypoglycemia in the first trimester. The risk of hypoglycemia is lower and the uncertainties over the safety of the artemisinin derivatives are greater. However, weighing this risk against the evidence that artesunate reduces the risk of death from severe malaria, both artesunate and quinine may be considered as options until more evidence becomes available. Treatment must not be delayed, so if only one of the drugs, artesunate, artemether, or quinine is available, then it should be started immediately. Dosages. Artemether plus lumefantrine. This is correctly available as a fixed dose formulation with dispersible or standard tablets containing 20 milligrams of artemether and 120 milligrams of lumefantrine. The recommended treatment is a 6-dose regimen over a 3-day period. The dosing is based on the number of tablets per dose according to predefined weight bands. 5 to 14 kgs, 1 tablet. 15 to 24 kgs, 2 tablets. 25 to 34 kgs, 3 tablets. And more than 34 kgs, 4 tablets, given twice a day for 3 days. This extrapolates to 1.7 per 12 milligrams per kg body weight of artemether and lumefantrine, respectively, per dose. Given twice a day for 3 days with a therapeutic dose range of 1.4 to 4 mg per kg of artemether and 10 to 16 mg per kg of lumefantrine. Artemisinin, the only recent change is the higher maintenance dose of parenteral artesunate recommended 2.4 mg per kg body weight, which is based on pharmacokinetic and pharmacodynamic studies, and by extrapolation from studies with oral artesunate. Quinine treatment for severe malaria was established before modern clinical trials methods were developed. Several sorts of quinine have been formulated for parenteral use, but the dihydrochloride is the most widely used. Peak concentrations following intramuscular quinine in severe malaria are similar to those following intravenous infusion. Pharmacokinetic modeling studies suggest that a loading dose of quinine, that is 20 mg salt per kg body weight, twice the maintenance dose, reduces the time needed to reach therapeutic plasma concentrations. The maintenance dose of quinine, 10 mg salt by kg body weight, is administered at 8-hour intervals, starting 8 hours after the first dose, following initial parenteral treatment, once the patient can tolerate oral therapy. If it is essential to continue and complete treatment with an effective oral antimalarial using a full course of an effective ACT. artesunate plus amodiaquine or artemether plus lumefantrine or dihydroartemisinin plus piperaquine or artesunate plus clindamycin or doxycycline or quinine plus clindamycin or doxycycline. That is all for today, and thank you for your time. We shall meet next time on something else.